And thank you everyone for joining us for our VT Reach session, which stands for Virtual Teleconference, Reach, Explore, and Aspire to Careers in Healthcare. And tonight we are spotlighting obstetrics and maternal medicine.
And tonight we have Teri Cahill Griffin, nurse, and Kelley McLean, obstetrician. And so we'll let them take it away. And we'll start with Teri and her inspiration into medicine. And just a quick reminder that if anyone has questions, we'll be doing a Q&A session that they can add the questions to the chat, and Lily and I will ask them for you. So you can add them as we go or during them.
So I'll begin.
Yes.
All right. Welcome, everyone. Thank you so much for having me. It's a pleasure to join you all, and always happy to talk about nursing and my role and how I got here and where I've been. So I will begin by saying I'm a little bit salty about my journey into medicine, because medicine and nursing are intricately related. You can't have one without the other, but they are different. And they are completely different specialties. And so I have been a nurse for over 31 years now, and I work in the healthcare field all the time. And but I'm not a medical practitioner. So I've been a nurse, as I said, 31 years, and that journey has taken me into a wide variety of places as a nurse. And one of my favorite things about being a nurse is that you can do a lot of different things with a job like this. I have been a nurse in a hospital setting, in an ICU setting, in an oncology setting. I've been a nurse manager for a number of years in a hospital. And I have also been a nursing instructor, and now a full-time professor of nursing at the college level, and something I never would have thought about myself doing way back when I was a new nurse, when I was younger. I'm surprised that people don't realize that nurses haven't always had to have a college degree. And in fact, still to this day, technically don't need to have a college degree. I graduated in 1991 from a diploma program. And these programs through most of the 20th century were hosted by the different hospitals in any state in the United States. And you would go to that hospital and they had a school of nursing that you could go to. And it was about 3 years long, most of them. And when you came out of the 3-year full-time program, you were, you were eligible to sit and take your nursing exams and get your licensure as a registered nurse. But it wasn't until I'd been a nurse for about 10 years that I actually went back to school and got a bachelor's degree in nursing. I feel strongly that the college level is where nursing wants to be. We want to be a profession with our own body of knowledge and our own ability to drive our own practice. So I felt it was important that even though I was well qualified and able to work as a nurse, I felt it was really important that I go back to school and get a bachelor's degree. And I've enjoyed going to school. So as you can see that we moved on, and then 10 years after that, I went back to the same school, University of Hartford, and got a master's degree because I was interested then in teaching and in actually working at the manager level, which really does require a little bit of extra additional education. And then 5 years ago, I moved to Vermont. Most of that, my first 25 years of practice was in Connecticut, in Hartford, Connecticut, and in the greater Hartford area. But I moved to Vermont a little over 5 years ago. Best thing I ever did. Connecticut and Vermont are very much alike, but there's less people here and less traffic. And I love that every single day about Vermont. And it's really allowed me to flourish as a nurse in the way that I always wanted to be. So it was the best decision my husband and I ever made. And so I came here and began teaching at the University of Vermont. But I always love taking care of patients. So when I teach at the university, I have nursing students and I teach classes and I give exams and I do all of that professor stuff, but I can't get away from my love of taking care of patients. So I also have a second job that really fulfills that role for me. I work per diem, which means as needed, on the labor and delivery floor at the medical center, which is my specialty in nursing. And so I do that through the school year, 2 or 3 times a month, as time permits. And then now that we're about to finish school, you'll see me most of the time full time over the summer at the medical center, at the bedside, taking care of patients, giving medications, doing my assessments, and just what I call, just being a nurse, which is my favorite part of all the different jobs that I do. So I see you've already, the next slide. Yeah. And I see myself staying in this role at this point in my career. But as I said, when I started, I really felt like, and I always encourage my nursing students to explore all different kinds of nursing. You can be a nurse in a hospital setting like I am, or you can be a nurse in a clinic setting or in a school setting. There's so many opportunities for nurses to practice in a wide variety of settings. I have a number of nursing students, or now, nurses who work, for example, at the Visiting Nurse Association here in Vermont. And they go to people's homes and help them manage their healthcare needs in their home. And they love that. That's their calling, and that they are very passionate about doing that. And as part of their role, they really bring in all the different caregivers and family members, and really look at the whole picture of a patient in a way that we don't get to see when the patient comes to us in a hospital setting and they're in our environment and we're doing things to them, and it's very different relationship. But when nurses are in the home, they really are there to serve the patient and see the patient in their own environment and be able to assess what the patient needs best to be able to maintain their care at home. So I said all of this, that I'm full-time faculty and that I am a registered nurse. And as a registered nurse, I work with a large group of nurses who mostly work 12-hour shifts, I would say. A typical day for us is 12 hours. If you work full-time as a nurse in a hospital setting, you'll do 3 12-hour shifts in any given week. And that's typically considered a full-time schedule for a nurse. And these are either 7 in the morning till 7 at night, or 7 at night till 7 in the morning. And night shift traditionally is where new nurses go when they're first come into the hospital setting. They go to the night shift. As you can imagine, that's not the most popular time of day when people are seeking a career. The idea of working all night every night is rather daunting. So there's usually openings in any given unit on the night shift to start when you're first a new graduate nurse. But you can quickly move up into a day shift position over time once you've put in some time in the organization. And we work one-on-one in labor and delivery with the patient who's laboring. We support them during their labor. And we give medications and we perform assessments, and we work closely with the medical team to make sure all of the patient's needs are met. But we're very fortunate in that particular environment where it's typically one nurse to one patient. That is not the average setting for a nurse. Most of the time, nurses will have a variety of different patients all in one assignment, depending on the acuity of the patient, depending on how sick they are and how great their needs are. So for example, we are in labor and delivery and we deliver to the babies, and we make sure everyone, mom and baby, are stable after delivery, that no one is having too much bleeding, that the baby's able to start breastfeeding and is nice and warm and happy. And then we transfer them to what we call the mother baby unit, the postpartum unit, which is right down the hall from us. And they're not one-on-one with their nurse. The nurse over on the mom baby unit would have 2 or 3 different couplets of moms and babies to be able to take care of. And that's a typical assignment for the nurses on that particular unit. And our roles are very, very different. Because I'm one-on-one with that patient, and things are pretty intense. The acuity of the situation when moms are delivering is such that you need a nurse at the bedside at all times to be able to monitor the baby and to be able to assure that labor is progressing, as is expected. But over on the postpartum floor, the emphasis for the nurse really shifts to teaching that patient, teaching that mom, and teaching that baby how to become an effective team, and how to become parents, and how to establish breastfeeding, and how to care for their newborn, how to bathe the baby, how to swaddle the baby, putting a baby in a car seat. Not an easy thing. I don't know if any of you ever tried to put a baby in a car seat, but they don't go in so easy. Those things are very complicated. And it can take new parents a little bit of time to get acclimated to those kind of responsibilities. And the nurse is their guide over on the postpartum floor to make sure that they have the ability to be able to put it all together to safely care for their newborn. And in between the two of us, mom baby down one end of the hall, and us in labor and delivery is a NICU. And that hopefully you won't necessarily need to go there. You go right by there if you've had a normal vaginal delivery and a happy, healthy baby. Then you bypass the NICU. But we're very fortunate at the University of Vermont to have a very cutting edge NICU that takes the most sick babies and works really hard to make them well. And the responsibilities of the nurses in a place like the NICU is very intense one-on-one with that baby. And much like in labor and delivery, their focus is on giving medications and assessing the baby specifically, and providing support to stabilize those babies. So yeah, when I'm not working in either labor and delivery or at the teaching role, I'm trying to do better with my work-life balance. I had joked with those people who got me up and running in this program that this isn't something I do well. I fully admit I tend to work a lot. Like I said, I already booked myself to work full-time this summer. I don't know why. I just feel the need to do that. But Vermont is really enticing me to get outdoors more and to really take advantage of all the great nature and fresh air and less people and less traffic. So I really work really hard to get outside more. So this summer we actually booked several camping trips right in the Vermont area, just to get away for a day or two here or there to make that leap where I'm kind of forced to get outside and put away the work for a little while and do some work-life balance. So that's my challenge for me as I move forward.
Well, thank you, Teri. And we are now going to hear from Kelley McLean and her inspiration into medicine.
Okay, can everyone hear me?
Yes.
All right, that was great, Teri. I was thinking we should do some kind of I always want to do a day in the life on labor and delivery with the nurses and the doctors switching roles, but it'd be nice to just share background because we all work together really closely, but because our roles are so different, we don't often know each other as well as we ought to.
I agree.
Yeah. Okay. So I will also talk about this, and I have a really different background and path than Teri, so it's a nice contrast. You know, I'm from Denver, Colorado, and went to college at Claremont McKenna in California, which is a small liberal arts school with a focus on, you know, it puts out a lot of financial people and some lawyers, not very many people going into the health fields. And I wasn't thinking that I wanted to go to medical school, but I took a biology course and I thought, you know, I really like this, and I liked it in a way that I wasn't liking other things I was doing. And I thought I really, you know, hadn't thought myself as a science type person, but I really loved it. And so I thought, well, maybe I do want to do something. And I really enjoy people. I wanted to go into an area where I felt like I was doing some good. And I thought, for a long time about being a teacher or professor. I just, I wasn't sure. But then as I sort of moved through college, it became more clear that I was going into the sciences in some way, either to get a PhD or to get a medical degree. And, it's interesting because I didn't have a lot of exposure to the health field opportunities more widely. So I didn't know any nurses. No one talked to me about nursing programs. I didn't know any physician's assistants. I didn't even know that was a thing. I had very little exposure to medicine in general. And so, to me, I think at the time, I'm 20, I thought, well, I'll either get a PhD or medical degree, which is, I think happens a lot. I ended up doing 2 years of research which I left out of my little Weaver thing, but there you go. Went to Claremont McKenna College, but I didn't go straight to University of Colorado School of Medicine. So I took a year and did a year of research at National Institutes of Health, doing breast cancer research and ovarian cancer research, which I really loved. And I worked with wonderful people, and I loved it so much that I actually took another year, which took some finagling, but the University of Colorado allowed me to hold and come in a year later. And it was a really important time for me, I think, to figure out, that I really didn't want to go into medicine. I really didn't want to do basic science, although it was an important period to learn that. And I met a lot of wonderful people, and I matured a lot. And I think it helped me come into medical school a lot more mature. So I went into University of Colorado School of Medicine, where I'm from. And so ultimately I decided to go there because it was cheaper. But it was a great school. And then for residency, I think the next slide, maybe. Yeah. So I came to University of Vermont for residency, and, it is a crazy how life happened, and you think you're in control, but you're not really. There's the match system, and University of Vermont was my second choice. Colorado was my first choice, and it never even dawned on me that I wouldn't get my first choice. So when I got the letter I was moving to Vermont, I was shocked. I knew very little about Vermont. I had ranked it second because I loved, when I visited, I loved the program. It was small. People seemed like good people. I thought the program would fit me. And of course I loved Burlington. So I ended up matching and complained for an entire year about the lack of sunshine. And I think drove every single person I knew crazy. Well, back in Colorado. And then I decided to stay for fellowship. I interviewed really widely, and our program is a really, really strong program for fellowship, which I didn't fully recognize until I interviewed at University of Wisconsin, University of Chicago, University of Colorado, University of Utah, all the sort of, like seven different places that, sort of allow both great training and also a wonderful place to live. And I really wanted to stay here. So I stayed for fellowship, which is 3 years after residency, and that is in maternal fetal medicine. And so I'm a subspecialist for high risk pregnancies, either for maternal disease or for fetal complications, but I do a lot of low risk obstetrics as well. And now I'll never leave here. I'll die here. I'm trying to get everybody I know to move to Vermont instead of staying in Colorado. And it's just been a wonderful place, and it's a wonderful place to work. But my trajectory, unlike Teri, was very sort of direct. I had an idea in my head of what I wanted to do. When I got to medical school, I did not know what I wanted to do. And the rotations were really important. I think, exposures are really important. And in particular, if you're going to go into medicine, exposure is so important to know if you really want to do it and what you want to do. Because with nursing and with physician's assistants and with a lot of different things, you can sort of switch. If you don't like being a labor and delivery nurse, you can do something else. And if you don't like being a physician's assistant in the emergency room, you can go and be an interventional radiology, PA. And with medicine, it does stick people. If you finish a residency and you figure out this is not what you want to do, it's a big deal to change. And a lot of people do it, and they do it well, and they're doubly trained. Some people don't, though, and they decide to stop practicing and to have a whole different job. So I just, the more exposure I think people can get to all kinds of areas, once it's like the first hurdle is, you wanted to go into healthcare. So that's great. That's a huge hurdle. But then, do you want to be a dentist? Do you want to be, do you want an RN? Do you want a PA? Do you want an MD? I mean, and why do you want that? And then what do you think you want to do? And in a lot of ways, I'm very lucky. I love my job. I think that I'm, pretty, I fit well for the type of job that I have, but a lot of that is luck. And the path brought me here to a place that works for me really well, but there's definitely a piece of luck in that. So, all right, next slide. Okay, so responsibilities, maternal fetal medicine, physician. A lot of people are like, what is maternal fetal medicine? So I am an OBGYN. My residency was OBGYN, but the fellowship is specific to higher risk pregnancy. So I don't do any gynecology. I do not do any gynecologic surgery. The only surgery I do is our cesarean deliveries and some other kind of more specialized procedures in pregnancy. I see, women who are quote unquote high risk because of pre-existing diabetes, or they have chronic hypertension, or they have other chronic medical illnesses as they come into pregnancy. Or there is something wrong with their fetus, like a major cardiac defect or another structural abnormality or chromosomal abnormality. And historically, maternal fetal medicine docs have done a lot of prenatal ultrasound and prenatal genetic diagnosis. So we do amniocentesis to assess genetics, to diagnose things like Down syndrome and other more rare genetic differences. And so I do a lot of prenatal ultrasound, which, anywhere from 12 weeks all the way up to term, looking at the fetus's growth and trying to assess when delivery is safest and what may need to be modified in terms of care. I also, though, have had the opportunity to do a lot of different things. And I would highly recommend that whatever, people go into in healthcare, that they work at an institution, in a department, in an area where there's a little bit of flexibility to help you do the things that you want to do. And if there isn't, that makes the job really hard. And you may not have a lot of flexibility when you first come in, but by mid-career, you should be able to do the things that you want to do, or you may be willing to do something, go somewhere else. But I'm the medical director for our certified nurse midwifery group, which is really wonderful. We have a great group of midwives, and I've learned a lot from them, and I continuously learn by being their medical director. And that's been really fun. I do a lot of research with our chairman on clotting disorders in pregnancy, and we have a federally funded grant where we do research with some of our patients who come through in the third trimester of pregnancy. I get to do a lot of quality work, both locally, and there's a perinatal quality group that UVM and Dartmouth kind of co-lead, but we cover hospitals in New Hampshire, almost all hospitals in New Hampshire, all Vermont hospitals, some in Massachusetts, and many in Maine, including Maine Med. So it's a really solid group, and we get to do a lot of great work. And then I get to do teaching. So I teach medical students, I teach residents, and I teach our maternal fetal medicine fellows. Okay, so this is a sort of, work-life integration is always hard. I think work-life integration is hard these days for most people, kind of regardless of whether you're in healthcare or not. And some of it is because you are technically available 24/7. You've got a phone. People know that. If they text you, they know you should answer right back. And so I think it's a different balance these days for many people in many different jobs. I am 80%, so I don't work on Thursdays, and I made that choice when I had my daughter, and when she was about 2 years old, I was very unhappy. I felt like I wasn't a very great mom, and I wasn't being a great doctor because I was just overwhelmed. And so I decided to go down to 80%, which was sort of life-changing for me. And so the way our service works, we kind of cover the full service and all of the antepartum high-risk pregnant patients once a month. So 1 week out of the month, I'm working a lot. And then the other 3 weeks, I do clinics, I do some teaching. There are some didactic type lectures that I get to go to. I have some research time. I have some blocked time from my midwifery what I need to do for our midwifery group. So it's a huge mix of things. I have to look every morning at what my calendar is because I don't know what I'm doing. So every night before work, I look to see what time I have to be there and what I'm doing, because it changes every day, which I love. I love it. But I couldn't find my balance working full time. And then we take overnight call. I don't take a lot. I take overnight call on the weekends, occasionally, and then over holidays, but I take a lot of backup calls. So a week of call a month where I'm on 24 hours a day as backup if people need it or have questions or anything like that. So this is my work-life integration. So I'm a big runner. So I'm running the marathon. I have time to do those kinds of things that are really important to me, and having that day off a week made a huge difference for me to be able to do those things. I've got an 8-year-old daughter. We spent a lot of time with her, and an awesome dog. And I'm in a 2-physician household. So that, everything is tight with timing and with schedules. And so, being able to advocate for oneself going through and deciding, you know what, I'm not balanced, I'm going to change something. And that was really great for me. All right.
All right, so I'm going to bring you both up, and anyone can add questions to the chat. I had a question for you, Dr. McLean, about really the difference in roles as a resident and fellow. What the difference, because you're a student in both senses, but do you have a lot more responsibility as a fellow?
So the residents have, this is good because it confuses people kind of all along, but you finish medical school, you have a medical degree, technically you're a doctor, although you have very little experience, and you come into residency, and that's where you gain a lot of experience. And residencies vary in terms of their length and range from 3 all the way up to 5 to 6 years. And so an OB/GYN residency is 4 years, which there is talk of the need to lengthen that. There's a lot to learn. And obstetrics is pretty different than gynecology and vice versa. So they have a lot of clinical responsibility. They are mainly clinical, and they are the heavy lifters of the service on the dock ends. They do most of the orders. They do a lot of the logistics. They round early in the morning. They're kind of the workhorse of our inpatient unit. And then they learn, they rotate through the outpatient side and things like that. So it's service heavy, but as much education in other ways that we can do. They don't get a lot of research time. They get some research time. And then the fellowship is very focused on maternal fetal medicine. There is a fellowship in reproductive endocrinology. We have a fellowship in our program that we train reproductive endocrinology fellows. They do like IVF procedures, in vitro fertilization. And then there's GYN oncology for women with gynecologic cancer. We do not have a fellowship program here, but we have GYN oncologists who operate with our residents. So the fellowship, there's more time for research. It's much more sort of outpatient clinic heavy, and very specific to maternal fetal medicine. So a lot of ultrasound, amniocentesis, and a lot of like consultative medicine.
Okay, thank you. And there's a question in the chat, which is for both of you to answer. And the student is asking if either of you have advice for prospective women's health nurse practitioner or certified nurse midwives, maybe in terms of, things that they can be doing in order to gain experience, or just, any type of life advice as well.
I can start. So if you're interested in being a women's health nurse practitioner or a certified nurse midwife, most of the time you'd want to be a nurse first and get your undergraduate degree in nursing. Although that's not necessarily the only way to do it. There are some direct entry programs so you could find. But most of the recommendations are that you have an undergraduate degree in nursing, and then you're going to look for a school that offers not only the nurse practitioner program, but specific to nurse midwifery or nurse practitioner in women's health. Not every program offers those. For example, at UVM here, we have a doctoral program. I just finished, I got my doctoral degree, but I'm not a nurse practitioner. So you want to carefully look at the program to make sure it's what you want. And we do have a nurse practitioner program here at UVM, but it's not in women's health. There's a family nurse practitioner program. There's a geriatric nurse practitioner, but it's not in women's health. For that, you're going to have to look elsewhere. In Michigan and Wisconsin, there's some really, really good schools for women's health nurse practitioner, as well as midwifery. There's some really great schools to be a nurse midwife. But it's one of those things, nursing, it's always as clear as mud because there's a million different paths to get there. You can be a nurse midwife, you can be a midwife, you can be a certified nurse midwife, you can be a midwife who's a nurse practitioner. And any combination of those things is acceptable to be able to practice in most of the other settings that we're talking about. So the most popular one for nurse midwifery, or the most well-regarded, is Frontier. If you Google Frontier midwifery program, they have a great program in certified nurse midwifery, and their website will actually talk you through a lot of the foundational courses that they want you to have and what kind of undergrad degree you should have. But what I will say before I turn it over to Kelley is that when you're in an undergraduate nursing program and you know that women's health is your passion and you know you want to be a midwife someday, it's still super important to focus on the whole patient and the whole lifespan. I think sometimes undergraduates get very focused on only putting the time and the effort into things like their labor and delivery rotation and the newborn nursery and those things. But I would strongly recommend that you do really, really well in all of the rotations, especially your adult health rotations, and be really comfortable assessing a patient, any patient, and knowing the pitfalls of nursing in any setting, which is what an overall education, will give you. And then when you're in graduate school, that's the opportunity to really specialize. And so that would be the path I would suggest, is focus on the undergrad and get as much experience as a nurse as you can during those years of training.
Yeah, no, I agree with that. And just what you're saying, like Frontier, for instance, for nurse midwifery is a really good program. You do want to be cognizant of sort of where the program has you rotate and to get your clinical numbers and your deliveries. I know that it can sometimes be an issue because we take midwifery students from other programs sometimes that, the students are struggling to get sort of accepted at another institution to get the numbers they need to graduate. So that's a lot of pressure. And so you want to know with, each program kind of how it works and how you're going to get your clinical experience that they require for graduation.
That's a really good point, because it's not like when the physician does the residency program or the fellowship, they're at the institution again. And so the patients are there for them to be able to work with. But in a lot of the midwife programs and in the nurse practitioner programs, you really have to seek out and be an independent learner and seek out those clinical experiences with the guidance of the faculty in the program. A lot of the legwork is up to you to find a lot of those experiences, and different programs, will offer different levels of support depending on their size of their program and what they have available.
Thank you. A question that kind of goes right with that from the chat as well is, do you know any specific programs that are good for becoming a certified nurse midwife other than the Frontier program?
The other one that I love to talk about is in Bay State in Springfield, Mass, has an excellent nurse midwifery program. It's an old program, but it's very traditional in its approach. And in a place like Bay State, where they have the clinical sites, they have the patients, they have the experiences that they can offer you. In a place like Springfield, Mass, you've got a lot of population there, right, in Springfield, and then all the way down to Hartford and so on and so forth. There's just a lot of opportunity geographically in that area, and it's a well-regarded program. But you want to look for programs. You can just look around online, see what you see. Google certified nurse midwifery programs. But you want to look for programs that are accredited by the American College of Nurse Midwives. So that's something you want to, as you're looking at the banner and looking at, at their flashy page, you want to make sure that much like UVM or other colleges that you're interested in, you want to make sure that the program is accredited by the people who are actually the governing bodies of these, of the specialties.
Yeah, I agree. And, the other point to make, well, and also our midwives are really, they're passionate about education, especially education of people who would like to become certified nurse midwives. So, they would be happy to answer, I'm sure, some questions if people reached out to them. And then the only other thing to say is, it's a lot of training and on top of, your nursing degree, and it is very specific. So you can always use your nursing degree to do other things, but I think, again, the exposure. So if you have the opportunity to be a volunteer doula, or to, work for a short time as a medical assistant in an office to really get a sense, the midwives spend a lot of time and work a lot with, with their patients, and they're in the room a lot, and it's physically hard. And most certified nurse midwives are set up that way, where it's a lot of labor support, and you just have to know that's what you want to do.
Thank you. Yeah, definitely all very good advice. And then just another question from the chat that I'm not sure the two of you know the answer to, but what route would be best for those interested in surgery around women's health? Would that just look like a then different residency / fellowship, or what?
So surgical procedures specific to women.
Yes, I believe that is what the question.
Yeah, I mean, so general OBGYNs are surgeons, and they do a lot of benign surgery for ovarian cysts, and they do hysterectomies, and they do, a lot of gynecologic surgery. But the people who are most surgically oriented are the GYN oncologists who do cancer surgery for women with gynecologic cancers. So, and then if, we have some wonderful breast surgeons at the hospital who manage our patients with breast cancer, and they go a whole different route. They are not OBGYNs. They are, they go the general surgery route and make their way to breast surgery. So there are different ways to do things. And then, of course, you can always become a general surgeon and have a more highly female patient population, and that's a great way to go as well.
Thank you.
I think, Kelley, the point, what's clear though is I have really not much to add, because really, if you were interested specifically in surgery, that's a medical track that you're going to want. Nurse midwives will do some basic, stitching of the perineum after a delivery if they needed some basic procedures. But if you're interested in surgery, you want to be a doctor. That really isn't the purview of a nurse practitioner or even a midwife. If a patient is laboring with a midwife, for example, and it's decided that they need to have a cesarean birth, they're going to call their physician colleagues and have them come in, and the physicians would be the ones to do the actual surgery.
Thank you. Teri, I had a question for you. Do you feel, with your nursing experience, what prepared you for teaching, and what do you like the most about it?
Oh, I would have said even 10 years ago, I would have said I'm not a good teacher, that I talk too fast, I think too fast, I've got too much on my mind. And I always admired those who could eloquently present information in a way that made it easy for people to understand. But I really found that I enjoyed, especially in the clinical setting, teaching students one-on-one, being in the room with a patient, talking with a new nurse about what I was seeing, what I was observing, what I thought was important. And so it kind of grew on me. And then I had the opportunity to work part-time, again, that work-life balance thing. I was working full-time as a nurse manager, and oh, by the way, will you take a clinical group a couple evenings a week? And sure, why not? And I started doing that on a regular basis, and I just fell in love with the teaching aspect. I think there's a certain amount of confidence you need to have in the material before you can teach it really well. And so I got to a point in my nursing career where I really felt like I knew a lot. I had a lot to pass on. I have a lot of knowledge and experience, and people seemed interested in what I had to say when I would say it. And so to me, that's what brought me to teaching, and the balance I find with that is really striking. And what the students give back to me, though, is that love of nursing. So, you might have met an older nurse or two. Sometimes we're a little, can be a little worn down from the year. You've seen a lot over the years, but working with students just brings that whole freshness to the experience, to see it through their eyes, to see the patient the way that they're seeing it in a new and exciting way, that they just inspire me all the time, to give their first little injection to a baby. They're like, oh my God, and it's so nerve-wracking. And I talk them through it, and we talk about what we're going to do, and we get everything all ready. And then their joy at being able to perform a procedure successfully, and everything is well, and everything went great. And I just am inspired by that all the time. I love to do that.
Wow, thank you. That's so great to hear. And another question that can be, I think, applied to both. The question refers to nursing school in general, but I think the same would go for medical school. If you have any tips for studying through these two types of programs where you're getting so much information over the course of those years, and if you have any tips for studying or how to try and retain all of that information.
Well, I'll just start with what I wish I had done when I was a medical student, and even a resident, is, one thing you really can't sort of cram in all of these things. So you got to do a little bit at a time as best you can, but you also, to memorize a bunch of facts to pass a test, I recognize that there are some things that and times that needs to happen so that you pass the test. But, the true knowledge that you'll have for a long time that you can pull from, and that, becomes your own background of what you understand and what you may or may not have seen, but what you have, read about and understand well enough that seeing it for the first time, you might really know, is anytime that you clinically, like when you're going through your clinical rotations or your clinicals in nursing school, anytime you see something, go home and read about it. And like, if you have to reference the formal resources that you got from school, great. If you have to add to it, great. But you will remember 1,000 times better, and it suddenly has a lot more meaning when it's attached to a human. And so anything, or you read something in the newspaper about, you read about anything, and you just look it up and you read as much as you can in the healthcare field, even if it's in the lay press, and things start to stick better.
We always say in nursing that, we tell stories. It's how we learn from each other. And we're going to talk about it, and we're going to use that very same thing when we do a case study in just a couple of minutes, that it's about the totality of the experience and taking it all in. And so it's best done really by storytelling, and this patient and this story, and then this happened, and then that happened. And I would say, knowing where your resources are, knowing where you can find those normal lab values, if that's what you're looking for, knowing how to quickly and efficiently access that information, but not hyper focusing on that, seeing things, the big picture. If you're in a big lecture and you're learning pathophysiology, and they're doing the cardiovascular system, and take it in, absorb the content, think about what they're saying when they're saying it, rather than trying to write it all down furiously. Record it if you have to. If most lectures are available to be recorded these days, if you really learn best by taking notes, take notes after, but listen to the story that's being told and try and picture it as it's being it's unfolding in front of you, and concentrating on thinking big picture and not getting too bogged down in those details, because you're so right. There's so much detail. There's so much to learn. You can't possibly know all of those things. Like Kelley said, for the test, you can study those lab values, you can regurgitate it on a test, but in terms of what does that mean for the person that you're caring for, that's what you want to be thinking about. How does this really affect the person that I'm caring for? And why is this important that I know this information? And what difference will it make for that person?
And I agree with when you have a lecture, the person giving the lecture has been well vetted and in almost always, is sort of a wealth of knowledge. And so if you can just listen, don't write notes and put the phone away because, it's so, and even the computer, you just shut it down. It's so easy to have your attention flit away for a quick second. And like, if you can just hold your attention for that period of time, and then you can go back and write notes or anything else, but it makes it so much easier to learn what you need to learn if you can block everything else out for that hour.
Yeah, agreed.
Thank you. And I have one more question for the time being, and then we'll move on to the case study. But for someone who isn't pre-nursing or did a nursing undergraduate program and say graduated with a degree in biology, what would be the best way for them to go into nursing afterwards?
There's a lot of programs available for someone like that. We call it the direct entry into professional nursing at UVM. It's called DEPN. And if you want to be a nurse practitioner, the direct entry program at UVM is an avenue where you can have a degree in any other kind of field. You have a 4-year degree in biology is a great one, but it could be in English, music theory, it could be in any number of things. But there's also a ton of programs who in a year, or maybe even just a hair more than a year, will give you an undergrad degree in nursing once you've had a degree in another field. It's basically just concentrated on that nursing portion, and then you would graduate with a nursing degree. Many schools in our area, even at UMass has one, UConn has one. University of New Hampshire, they all do. They all have that direct entry. What's also available to someone who has a degree in another field, who really just wants to be a nurse, who doesn't want to necessarily go on to be a nurse practitioner, getting that extra degree isn't super important in that person's particular case, then you want to look at the community college system. They produce some really excellent nurses. CCV has a great nursing program that's about 2 years long. It doesn't really matter if you had a degree in another field, but in terms of getting a job as a nurse, to be able to say, oh, I've got a bachelor's degree in biology and now I've got a 2-year degree from CCV, that's great too. That's a really good alternative pathway into nursing. There's a number of ways you can go about that.
Well, thank you to the both of you, and we'll have another chance to ask some more questions if anything comes up now, but we'll turn to the case study, which I'll let the two of you go through.
Okay, I guess I'll start. I submitted this case study, and the reason I submitted it is it's I think pretty easy to follow. It was it highlights a lot of things about, there's a lot about obstetric care and then, gynecologic care and care of a woman all through her, just like you said, Teri, all the way through menopause and beyond, that, that's just really important. And a lot of it is normal care of healthy people, and that's the majority of the care. But there are times and cases that stand out where, terrible things happen. And I just wanted to, this case highlighted this patient needed a lot of support from the medical system, including nurses, sort of all hands on deck, the pediatricians and the neonatal intensive care unit docs, and the ethicists. We've got just some incredibly talented, really smart ethicists at our hospital that do just such great work. And so anyway, I wanted to highlight this because you can follow it, and it has some really terrible but great pictures to look at. And this happened when this is a case that happened quite a while ago when I was a fellow. And this patient was transferred into our service at 24 weeks of gestation with twins. She had a mechanical heart valve, which we don't see in this country very often. Most young women have bioprosthetic valves that can be, need to be replaced, unfortunately, every so often. The beauty of a mechanical heart valve is once it replaces the native valve that's not working, or with something wrong with the native valve, it's kind of good for a long time. The issue is that person needs to be anticoagulated, because blood clots can form on the valve and then make their way to other places in the body, which is what happened here. And pregnancy is a hypercoagulable state. We're all constantly having little clots and then breaking them up, and we're all doing this balance. If you run into your dresser and hit your thigh, you get a little bruise there. And those are, little clots that are helping you to not bleed. But obviously having too much clotting can kill you. So there's a constant balance, and pregnant women are tipped towards they clot more easily. And, evolutionarily speaking, that makes sense, because it turns out, there's a lot of blood loss at delivery, and even in the process of conception and the implantation of that early pregnancy, women can have a lot of bleeding. And so the tip towards being more thrombotic or able to make clots better is protective. So this woman was transferred to us kind of mid-pregnancy on not the right anticoagulation or blood thinning regimen. And there was immediate recognition of that, but it took about a week to figure out what she should be on. And in the interim, she came in feeling pretty short of breath, and having, a lot of different symptoms. Once she was admitted to the inpatient side, she started complaining of really severe pain and skin color changes at her thighs, and her buttocks. The nurse taking care of her peeled down the blanket. Again, this is a multi, disciplinary talk here with Teri, and it's really important to get your hands on patients, and some of the docs, I think, were trying to figure out what was going on by thinking about it. The nurse pulled down the blanket and saw that the patient's legs were mottled purple, and bright white. She was getting no blood supplied to her thighs and legs. Next slide. So this is an image. It's a CAT scan, which then with some three-dimensional reconstruction that the interventional radiologist did for us, showing this twin pregnancy in her uterus. And you can see that the contrast that we should be able to see, the blood coming all the way down the aorta, it just stops, just completely stops. And then sort of reconstitutes lower on at the internal iliac arteries, which are feeding the uterus. So the babies are alive, but in imminent danger, and she is in imminent danger of death. So this is a really serious case. So this was a lot of people were involved. Like I said, the intensive care unit, the general surgeons, the vascular surgeons, the radiologists, tons of different nurses from different areas. The intensive care unit, adult intensive care unit nurses are unbelievably talented and were so important in this case. She was in the ICU for a long time, but ultimately required opening that vessel up and removing the clot. And she had a lot of complications and some other procedures as well, but and then had her mitral valve replaced. So she had to go on cardiopulmonary bypass for that. One of the fetuses didn't make it through the procedure, and the other made it through, but with some brain changes that we could see via prenatal ultrasound over the course of the pregnancy. And ultimately that baby did not make it past the first couple of months of life. So not a happy case to share with you all, but the images are really striking, and it sort of highlights the importance of communication, the importance of listening to patients. That patient came in and said, I'm feeling short of breath, and everybody moved on that. It's just really important to listen to people. And that's true regardless of what area, what field you go into. And really good people who are really good at their job in healthcare listen. And a huge number of teams of people from all kinds of training backgrounds moved quickly into motion to save her life.
I think what strikes me about this one is, as you're talking about the different people involved, how much everyone had to work together as a team to, even the outcome wasn't as great as you might have hoped that it would be. Everyone had to work together. And so it involves, just as you said, Kelley, everybody has to listen to one another. And so when the nurse is pulling back the covers to reveal that, oh my goodness, that, there's clearly a bigger problem than we even thought, that then the rest of the team responded right away and said, oh my goodness. And for the nurse role in a situation like this, the doctors are working really hard to figure out what in the world's going on, and trying to run tests and to order medication and see if they can't make the best of this situation and figure out how to best help her. But the eyes and ears, many times while they're conferring with their scans and looking through the literature and trying to figure out what's going on, it's the nurse at the bedside during this period of time, like all the time. The nurse in the ICU probably never left her side during many critical periods of her journey. And so being able to function as a well-oiled machine, so that you are checking on the nurse and asking, changes in vital signs, or what, is the color improving in the legs, and that kind of dialogue, that's what makes for really good patient outcomes, is when that all can happen and everyone can just be very transparent of that we all need each other to be able to figure out, what's the best course of action, for a patient like this. It's just fascinating the amount of people who probably touched this one particular patient.
Yeah, that is true. We were just asked to include some images that highlight kind of what we do. I just, for fun, there's a little video or video clip of a triplet pregnancy. This is, kind of what I do on a regular basis, is a lot of ultrasound. There's some misunderstanding of obstetric ultrasound in this country. I think, people are excited to find out if it's a boy or a girl. I think, I guess we all do this. We all think, well, there wouldn't be anything wrong. And so when there is a surprise, it's often, it's very difficult for families and patients. And even, triplets can be a surprise that's, extremely life-changing, and not all in the good ways. But I do a lot of prenatal ultrasound. We have outpatient nurses and an outpatient NP and physician's assistant who work really closely with all of us in clinic and help clinic sort of run really smoothly. And that just highlights too the, even within an area, you can become a OBGYN and end up doing a lot of inpatient versus a lot of outpatient work. You can become a, labor and delivery nurse and decide you really want to be on the outpatient side. Actually, both of our high-risk nurses were labor and delivery nurses, and it was not for them. They didn't like the 12-hour shifts. They didn't like being on their feet all day. And they love looking things up and answering phones and asking questions, of us to call patients back with. They come to our didactic lectures and learn about high-risk obstetric medical things with us. And so, just to highlight again, there's a lot of flexibility in terms of how you spend your day, even within just women's healthcare.
I'm also thinking what you said about the support that's needed. I was thinking about, after a patient like this, her she stabilizes, but unfortunately her babies were lost. There's also perinatal nurse bereavement specialists. And because, as Kelley said, in this country, we don't tend to think about pregnancy that doesn't go well. We sweep that under the rug as a kind of a culture. We don't, everybody assumes if, yay, I'm pregnant, that's going to result in a happy, healthy baby. And most of the time it does, but not every time. And there's an entire subset of population of nurses and clinicians and physicians who actually specialize in how to best support moms and families when there's been a loss to their pregnancy. No matter how that loss occurred, it's a loss. And how can we best support people through some of the very difficult times that come with that? That's actually a significant part of all of our work that we seldom talk about, because people don't really want to talk about that. They want to talk about the cute babies, or we there's not a lot of stomach sometimes for the difficult conversations that we have to have with people, but also the support that we can offer, and that we readily offer people all the time when things don't go as they had hoped that they would.
And then we just wanted to include the responsibilities of both the nurse and provider during the stages of labor, if the two of you kind of wanted to delve into that.
Sure. Yeah. I mean, either way, it just highlights how really different our roles are, and really different jobs. And I think people who love nursing on labor and delivery would hate to be an OBGYN doctor. And I think that people who really love being an OBGYN doctor would not want to be a nurse. And occasionally you meet people who you think, ooh, you should have been a doc, or a doc that you're like, you should have been a nurse, because you want to spend all this time with the patient. And so we have really different roles, and we can't function without the other. And I think it's really important to, to say that often and communicate it widely. But even just with a normal, healthy labor, delivering a baby, there are a lot of pieces to that. And women come in early labor often. We try to have women do some early labor work at home. There's some variation in the tolerance for that, but I'd say in early labor, our nurses really support those patients the most. I don't know, Teri, if you agree.
No, I totally agree. I think, as I said, when we talked about preparing for this, the early labor, active labor, the physician or the provider, even the midwife, depending on how the day is going. If that patient's in the hospital, the provider role is really kind of hands off and letting things just unfold as they're going to unfold. If everything is normal and everyone's tolerating what's happening, the baby's heart rate is great, mom is coping with her discomfort, then this is really the area where the nurse spends most of her time with the patient, and very little intervention by a physician would be necessary. But then there's a clear delineation when we go from early active labor to the delivery of the baby, where that role really shifts. So when you go to actually be delivering the baby, that's when you need not only that team there, but you need that physician or midwife or captain of the ship, if you will. You need that person to be able to lead the team in conjunction with mom and what mom's wishes are through the delivery of the baby. But you would not, in a hospital setting, want to have that baby with just the nurse in the room. We can do it. We've been trained, but it's very not okay to do that. You really need a physician or a midwife to help with the delivery of the baby. And as well, the placenta. As we've talked about, that sometimes there are complications, and you really need skilled providers at the bedside to be able to navigate any of those complications which may come up. And that's beyond the role of the nurse. That is clearly the role of the provider during those stages. And what the nurse is doing, I'm still there. I'm still one-on-one with that patient, but I'm supporting in a different way. I'm supporting now the team and the mom in a different way. I may be adjusting medications, turning the patient, but I'm doing that at the direction of the physician at that point to make sure that the delivery is going safely. And I may have great ideas about how that delivery could go safely, but we would usually defer to the provider in the room to be making those decisions if any difficult decisions needed to be made.
And I think, just to your point, I agree. And it's really important in emergency situations that there's an identified captain of the ship, as you will,
Yes.
Especially in emergencies or situations that are putting mom or baby in danger. It's really important to kind of know who's in charge. And usually that's going to be the OB/GYN. Sometimes that's going to be the attending anesthesiologist. And occasionally it's going to be the senior nurse in the room who's been there 30 years. And both the doctors in the room have been doing this for not very long. So, that is important. But there's been a lot of work done in healthcare in general to ensure that there's recognition that everybody's voice is important, and that if you see something that isn't right, that you speak up. And it doesn't matter if you're the medical assistant, it doesn't matter if you're the labor and delivery assistant or the nurse, a resident, a fellow, or an attending. If it doesn't seem right and it's going to put the patient in danger, it's important to speak up. And I think that there's been a lot of work in team building and improving communication, because bad outcomes happen when the person who's in charge is blind to what is going on. And sometimes a nurse with 30 years experience will say, I think this is going on. And it's really important to listen. So, that's just that's a team thing. We all work together up there a lot, and there's a lot of variation. And this is true all over the country in every area you could go into. I don't know a lot about dentists, but any other area, there's just a lot of variation in experience. And, at times you have a lot of experienced people in a room, and in other times you have very inexperienced people. Which actually this is a nice
Perfect.
slide. So this is our sign out. We do this twice a day, especially in the morning. We do a very formal sign out, and this includes everybody. We have nurses here signing out, this night nurses signing out to day nurses. We have the physicians here, which include the residents. Some of these people are residents up front. They present the patients. I'm actually on service, so that's me in the back standing up. We have our anesthesiology colleagues, I think, in the back here somewhere. So it's sort of everyone who is involved in patient care on labor and delivery signing out. We call it signing out the board, which means, giving important details on each person in each inpatient labor and delivery room. And then the nurses go on to do a bedside specific handout, their patient to the person coming on. This is kind of a team sign out that we do. Most labor and delivery units across the country do this with varied ways of doing it. We've been working on doing it differently at times, and this is a little different than what we've done in the past, but communication is the crux of good patient care, and so many cases that go badly are because of a breakdown in just passing along information, not in an actual medical error per se, giving the wrong dose or cutting something we're supposed to cut. Usually it's someone didn't hear an important piece of information that was said. So that's our sign out, and just highlights the team. There's a lot of different people in terms of training background there.
Well, we'll leave this time for the final Q&A. So if anyone has any additional questions, they can add them to the chat now. I had a question, Dr. McLean, about the research you do, and you said that you have patients that you include in your studies, and how you kind of approach that conversation with the patient.
Yeah, we actually have a study coordinator who approaches most of our patients. There are different ways to do this, and the IRB is the institutional review board that sort of sets the tone for research to protect people. So I could never ask a patient who isn't my patient if they would be interested in research. I can only access my own patients. Otherwise, I have to put out advertisements. And so for our study, we actually advertise at Healthy Living and City Market and the graduate student website, trying to enroll people who are considering pregnancy or who are pregnant. So that's a good way to do it. The way to, if you are accessing one of your own patients, the institutional review board has very specific language that one uses to ensure that patients understand that that would be a completely, that they can do it if they want to, they don't have to in any way, and it will in no way impact their care. So we're really careful about that.
Thank you. And I also just had, we could probably make this our last question for you, Dr. McLean, as well. Just the fact that you state that you work primarily with higher risk pregnancies. And I was wondering, is it more common that these higher, like the problems that need to be addressed, that it occurs, um, I don't know if this is the correct terminology, but in utero, or do you more deal with complications that happen after birth, I guess?
I see what you're saying. I would say the majority of what I see on the outpatient side in particular are women who come into pregnancy with some kind of medical problem that then results in a more complicated pregnancy. So for instance, women with, um, you know, significant chronic hypertension or pre-existing diabetes are at much higher risk for having babies that are too small and for having placentas that don't function as well. And those pregnancies can become quite complex. And so I would say most of the women we see come into pregnancy with some diagnosis that then impacts their pregnancy outcome.
Okay.
Thank you. And then a final question we'd love to ask all of our panelists are, what are your favorite parts about working at UVM Medical Center or with the Vermont population?
Do you want to go ahead, Teri, or do you want?
My internet is acting up, so why don't you go first, Kelley?
Okay, I'll go first. I have had a really, what can I say? University of Vermont has been really good to me in a lot of ways, and is why I've been willing to, not be near my family, and to sort of build a life in Vermont. Is that it's been a really nice place to work, and some of that is institutional, but a lot of it is, most of it is departmental and divisional. So even though you work in a big institution and there are certain things about that institution that are important, a lot of it ends up being logistics in terms of like, what's the parking like there, and what's the food like there, and what's the structure, do they, important things too, do they care about research? Do they care about, do they truly care about patient outcomes, or is it about the bottom line? And you can sort of get a sense about those things. It's certainly when you're in the institution, you can, it's harder when you're not in it. But what's really going to impact you and in your daily life, and whether you're happy or not happy, is your smaller group of people that you interact with. And a lot of it has to do with the boss directly above you. So I have a division director who's head of maternal fetal medicine, who is wonderful and has been extremely supportive of my career and of the career of my colleagues. And that keeps us here. So I think that's really important. And then Vermont, Vermont is, while it's not the most diverse state, is becoming more diverse. And, the people we see coming from Somalia and Nepal and other places, really do sort of enhance what we're able to see at the hospital and who we're able to interact with. And then there's a lot of socioeconomic diversity, there really is. And so, and there's a lot to be said for having one big hospital. Things are a little more streamlined. I have a really good sense of what's happening with women's healthcare across the state. And I like that a lot. I get to do a lot of outreach with our small hospitals. I know a lot about each hospital, how many babies they deliver, how many C-sections they do, what their C-section rate is, who their midwives and doctors are, who their nurse managers are. So I like that.
Could you just quickly tell me what the question was? My internet was completely frazzled at the moment.
Yes. What is your favorite part about working at UVM Medical Center and or with the Vermont population?
Oh, that was easy. Okay, that's good. Yeah, it's the people. It's really the sense of team that I really feel. I feel very well respected as a nurse, and I feel like my voice is heard not only amongst fellow nurses but the whole team. And that's specifically to our unit and the people that I work with. And I just think that it's a very well-oiled machine. Not that we don't have our issues, you know, like every organization does, like healthcare does, but I feel like the whole structure of how our work is set up is really conducive to everybody having a say in how things progress. And I really, really appreciate that.
Well, thank you both for donating your time to us tonight. We could not appreciate it more. This was a fantastic session, and VT Reach is going to take a 2-month break for summer. So we hope everyone enjoys their time, and we will be back in August with our monthly sessions.
Thank you everyone for joining us tonight, and thank you to our wonderful panelists for speaking so passionately about their professions.
Thank you very much. Thank you for having us. Kelley, I'll see you in the morning.
Hey.
I hope everyone has a great night.
Okay, bye guys.
Yeah.
Thank you.
Good night. Bye.
Bye.
Thank you.